Hello everyone. I am Docsaab and I am delighted to discuss a topic of immense clinical importance, anaphylaxis. This presentation aims to provide a comprehensive review delving deep into the intricate aspects of this severe, potentially life-threatening allergic reaction. We will journey from its historical understanding to the very latest in diagnostic methodologies, pharmacological treatments, prevention strategies, epidemiological trends, and its profound long term impacts. My goal is to ensure we all walk away with a richer, more nuanced understanding of this critical condition, which is paramount for both effective management and ultimately for improving patient outcomes. So, let's start with a fundamental question. What exactly is anaphylaxis? At its core, it defines as a severe, potentially life threatening systemic hypersensitivity reaction that is rapid in onset. This isn't just your typical mild allergic rash or sneezing fit. This is a whole body emergency. Its key characteristics are its systemic nature, meaning it involves multiple organ systems simultaneously. This involvement can manifest in a wide spectrum from seemingly mild cutaneous symptoms like hives all the way to severe cardiovascular collapse with a dramatic drop in blood pressure and critical respiratory compromise such as severe difficulty breathing or airway swelling. The outcome of anaphylaxis is, if left untreated or improperly managed, can tragically be fatal. However, and this is a crucial point, it is highly manageable with prompt and correct intervention. This inherent risk, coupled with its treatability, underscores its profound importance. Rapid recognition and immediate appropriate treatment of anaphylaxis are absolutely critical for saving lives and significantly improving long term patient outcomes. Our understanding of anaphylaxis has evolved significantly over time. Early observations date back to Francois Magendane in 1839, who noted severe reaction in rabbits after repeated egg albumin injections. The term anaphylaxis was formally coined in 1900 by Charles Richet and Paul Portier, a discovery that earned Richet a Nobel Prize in 1913. These era also saw the emergence of related concepts such as Clemens von Peyrick's allergy in 1906 and Victor Hutinel's elementary anaphylaxis in 1908. Intriguingly, early treatments included attempts at desensitization by figures like Finkelstein in 1905 and Unger in 1923. Over time, the broader terminology of hypersensitivity classified by Jell and Coombs in 1963 provided a more comprehensive framework for allergic reaction which is still used today. Understanding the global epidemiology of anaphylaxis reveals a concerning picture. We are observing an increasing trend in both incidence and prevalence of anaphylaxis worldwide, with a global incidence rate estimated between 1.5 and 8%. This rise is particularly notable in westernized countries. These are distinct age variations. The highest incidence rates are typically seen in children and young adults, especially for food induced anaphylaxis. While overall rates may be lower in older adults, they tend to experience more severe reactions and have a higher mortality rate due to comorbidities and concomitant medications. Speaking of mortality, while relatively low overall, it remains a critical concern, and delays in epinephrine administration are consistently identified as a major contributors to fatal outcomes. Various risk factors predispose individuals to anaphylaxis. These include pre-existing atopic conditions, especially asthma, which significantly increases the risk of severe and fatal reactions. A history of previous anaphylaxis is also the strongest predictor of future episodes. Comorbidities like cardiovascular disease or systemic mastocytosis and certain medications such as beta blockers or ACE inhibitors can exacerbate reactions or interfere with treatment. The common triggers for anaphylaxis vary by age and geography but universally include foods, particularly peanuts, tree nuts, milk, and eggs, insect stings from bees, wasps, and hornets, and medications such as antibiotics, NSAIDs, and general anesthetics. Other triggers include latex, exercise-induced anaphylaxis, and in significant number of cases, idiopathic anaphylaxis where no clear trigger is found. It's important to recognize that this variation in triggers and management guidelines can differ across age groups geographic regions, and individual patient profiles. Now let's dive into the fascinating yet complex cellular and molecular mechanisms that drive anaphylaxis, starting with the most common form, IgE-mediated anaphylaxis. It begins with the sensitization phase where the immune system produces allergen-specific IgE antibodies. These IgE antibodies then undergo FcRI binding, attaching to high affinity receptors on mast cells and basophils. Upon re-exposure, allergen cross-linking occurs, where the allergen links multiple IgE antibodies, triggering a rapid intracellular signaling cascade. This involves key steps like tyrosine phosphorylation by line kinase and activation of Syk kinase, leading to downstream signaling. The culmination is mediator release, characterized by rapid degranulation of preformed mediators like histamine, tryptase, chymase, and carboxypeptidase A3, which are expelled almost instantaneously. Concurrently, newly synthesized mediators like leukotrienes, prostaglandins, specifically prostaglandin D2, and platelet activating factor are generated and released. These mediators acting in concert are responsible for the diverse and life-threatening symptoms observed in anaphylaxis, from vasodilation and increased vascular permeability to bronchoconstriction and smooth muscle spasms. While IgE-mediated reactions are the most common, it's crucial to understand that anaphylaxis can also occur through non-IgE-mediated pathways. These reactions present with clinically indistinguishable symptoms but bypass the requirement for IgE antibodies in their mechanism. One pathway is IgG-mediated, where IgG antibodies from immune complexes that can activate mast cells and basophils. Another involves complement activation, where anaphylotoxins like C3A, C4A, and C5A directly stimulate mast cell degranulation. Some reactions occur via direct mast cell activation by pharmacological agents or physical stimuli, such as activation of the MRGPRX2 receptor or even contaminated heparin. Other pathways can include neuropeptidase release, cytotoxicity, and T cell activation. Despite these varied initial triggers, the common endpoint remains the same: the widespread systemic release of inflammatory mediators. This ultimately leads to the profound physiological disturbances we see in anaphylaxis, including increased vascular permeability, generalized vasodilation, smooth muscle contraction, and fluid extravasation, all of which can culminate in the dangerous condition like airway edema, hypovolemia, and distributive shock. Accurate diagnosis of anaphylaxis is primarily a clinical diagnosis, relying heavily on the rapid onset of characteristic symptoms after exposure to a likely allergen. To standardize these, several widely accepted guidelines exist. The NIAID and FINE criteria from 2006, commonly used in the United States, indicate anaphylaxis is highly likely under three circumstances. First, an acute onset of illness with skin and mucosal involvement plus respiratory or cardiovascular compromise. Second, involvement of two or more organ systems acutely after exposure to a likely allergen. Or third, reduced blood pressure following exposure to known allergen for that patient. Building upon this, the WHO criteria from 2020 are quite similar, but they specify definition for hypotension. For example, a systolic BP less than 90 mm mercury for adults or decrease greater than 30% from baseline. It's crucial to understand that absence of cutaneous symptoms such as hives or swelling does not rule out anaphylaxis. Up to 20% of cases, particularly in children with food or insect sting allergies, may lack these signs. Most importantly, meeting all diagnostic criteria is not a prerequisite for treatment. If anaphylaxis is suspected, epinephrine should be administered first without any delay. Timely treatment based on strong clinical suspicion is paramount. While clinical judgment drives immediate action, advanced biochemical markers can be invaluable for retrospective confirmation of anaphylaxis, especially when the diagnosis is uncertain or when differentiating it from mimicking conditions. The most studied marker is tryptase, which is released from mast cells. It peaks between 90 minutes to 4 hours post onset and typically returns to baseline within 24 hours. Triplet boasts with high specificity for anaphylaxis and correlates with severity, but its sensitivity is limited, meaning a negative result doesn't rule it out. Accurate timing of blood sampling is therefore critical. Histamine, another mast cell mediator, peaks very rapidly within 5 minutes and returns to baseline within 15 to 30 minutes. This extremely narrow detection window makes it practically challenging to capture, and many studies show it doesn't offer superior diagnostic performance. More recently, kinase and carboxypeptidase A3 are emerging as promising, longer lasting markers of mast cell activation detectable for up to 8 to 24 hours. CPA3 especially is stable and non-invasive, even detectable in saliva, but both require more clinical validation for routine use. Platelet activating factor and its hydrolase, along with urinary prostaglandin D2, are theoretically promising due to their roles in anaphylaxis. However, limited clinical data and practical collection challenges hinder their widespread use. Looking to the future, genetic biomarkers may offer potential for predicting anaphylaxis risk and severity, helping identify high risk patients before an event. Finally, always keep in mind a broad list of differential diagnoses that can mimic anaphylaxis, such as acute asthma exacerbation, vasovagal syncope, panic attacks, scombroid poisoning, or even systemic mastocytosis. Careful consideration of this is essential to ensure accurate diagnosis and appropriate treatment. Let's be absolutely clear. When it comes to the pharmacological treatment of anaphylaxis, epinephrine is the first line, immediate, and definitive intervention. There is no substitute. Its powerful mechanism of action stems from its role as an alpha and beta adrenergic agonist. Specifically, its alpha 1 agonist effects cause potent vasoconstriction, which dramatically increases peripheral vascular resistance and blood pressure, combating shock and reducing swellings like angioedema. Its beta 1 agonist effect increases heart rate and contractility, thereby improving cardiac output. And its beta 2 agonist effect leads to crucial bronchodilation, relieving respiratory distress, and also help to stabilize mast cells and reducing further mediator release. The universally recommended dosage and route is intramuscular injection into the mid anterolateral thigh. For adults, the typical dose is 0.3 to 0.5 mg IM. For children, it's age and weight dependent, 0.15 mg IM for those weighing 10 to 30 kg and 0.01 mg per kg IM for those under 10 kg. Crucially, repeat doses can and should be administered every 5 to 15 minutes if symptoms persist or recur. Intravenous epinephrine is reserved only for the most severe refractory cases of anaphylactic shock and must be administered in highly controlled intensive care setting with continuous cardiac monitoring, as its systemic effects are much more profound. Regarding side effects of IM epinephrine, they are usually transient and mild, such as pallor, palpitation, tremor, anxiety, or headache. More severe cardiac side effects are rare, especially with correct IM administration. The key principle cannot be overstated. Delays in administering epinephrine are consistently associated with increased morbidity and tragically increased mortality. Time is true muscle in anaphylaxis. While epinephrine is the mainstay, several other medications serve as adjunctive therapies to manage specific symptoms or support the patient during and after an anaphylactic reaction. Antihistamines, both H1 blockers like the diphenhydramine and H2 blockers like famotidine, can help reduce pruritus, urticaria, flushing, and angioedema. However, it is vital to remember they are not a substitute for epinephrine and do not treat life-threatening respiratory or cardiovascular symptoms. Corticosteroids such as methylprednisolone or prednisolone are anti-inflammatory agents. They are thought to prevent protected or biphasic reaction by dampening the inflammatory response, but their onset of action is slow, often several hours, so they are always adjunctive only and have no role in acute anaphylaxis management. Bronchodilators like albuterol are inhaled medication that relieve bronchospasm and wheezing, particularly if respiratory symptoms persist after epinephrine administration. Intravenous fluids are absolutely essential for treating hypotension and restoring intravascular volume, especially in anaphylactic shock. For severe refractory hypotension unresponsive to epinephrine and fluids, vasopressors like norepinephrine may be used in critical care settings. Glucagon can be considered for patients on beta blockers who do not respond adequately to epinephrine, as it can activate adenyl cyclase of beta adrenergic receptors. Supplemental oxygen should be administered to all patients presenting with respiratory distress or hypoxemia. Regarding controversies, the routine use of antihistamines and corticosteroids specifically to prevent biphasic reaction is debated, as robust evidence for this particular role is still somewhat limited. The consistent message remains no adjunctive therapy should ever delay the prompt administration of epinephrine. Moving beyond acute treatment, robust prevention strategies are critical for individuals at risk of anaphylaxis. The primary strategy revolves around allergen avoidance. This means accurately identifying specific triggers through history and allergic testing, followed by comprehensive patient education on reading food labels, understanding cross contamination risk in settings like restaurants, and implementing environmental controls, for example, for insect stings. Emergency preparedness is paramount. All patients at risk must carry at least two epinephrine auto-injectors at all times, and both they and their close contact must receive proper training on how and when to use them. Personalized anaphylaxis action plans are essential tools. These physician sign plans clearly outline steps for recognizing symptoms and administering immediate treatment and should be shared with schools, workplaces, and caregivers. Wearing medical identification such as ID jewelry or carrying a medical alert card can inform emergency responders of existing allergies, especially if the patient is unconscious. Beyond strict avoidance, allergen specific immunotherapy aims to modify the immune response over time. A highly successful example is venom immunotherapy, which is remarkably effective, preventing 80 to 98% of severe reaction from insect stings like bees, wasps, and hornets, and is the standard of care for those allergies. The landscape of prevention is rapidly evolving with innovative immunotherapies. Oral immunotherapy involves controlled incremental ingestion of tiny amounts of food allergen to build desensitization or sustain unresponsiveness. A prominent example is Palforzia, an FDA-approved peanut allergen powder for peanut allergy, which aims to reduce the risk of severe reaction from accidental exposures. Similar in principle is sublingual immunotherapy, where purified allergen extracts are placed under the tongue. Research on peanut slit, for instance, has shown promise in providing durable desensitization. Epicutaneous immunotherapy utilizes an allergen patch placed on the skin, such as the Viaskin peanut patch, to deliver allergen and achieve desensitization through immune cells in the skin. For certain critical medications, drug desensitization protocols can temporarily desensitize patients, allowing them to receive life saving treatments they would otherwise be allergic to. Anti-IgE therapy using monoclonal antibodies like omalizumab works by binding free IgE, preventing it from activating mast cells and reducing overall allergic reactivity. It also being investigated as an adjunct to OIT to improve safety. Emerging treatments like anti-interleukin 4 and interleukin 13 therapies, exemplified by dupilumab, target key cytokines in allergic inflammation. Looking even further ahead, virus like particle vaccines are nanoparticle based approaches where allergens are integrated into virus like particle to induce a protective immune response, with peanut VLP vaccines currently in clinical trials. Finally, a significant shift in recent years is the recommendation for early allergen introduction in infants at high risk. Influenced by landmark studies like the LEAP trial, this strategy has proven effective in preventing the development of food allergies, a stark contrast to previous avoidance recommendations. While acute anaphylaxis is often survivable with prompt treatment, the long term prognosis and potential complications extend far beyond the immediate event. For individuals experiencing recurrent episodes, there is an increased risk, and while rare, repeated severe reactions could potentially lead to cumulative organ damage, especially in those with underlying conditions. However, a major and often underestimated impact is on the quality of life. Anaphylaxis profoundly and negatively impacts health related quality of life. This includes reduced participation in daily activities, social isolation due to the need to avoid triggers, and constant mentally exhausting vigilance in all environments. The psychological burden is substantial. High levels of anxiety and pervasive fear of recurrence, elevated rates of depression, and even symptoms consistent with post traumatic stress disorder are commonly reported, particularly in individuals who have experienced life threatening reactions. There is also a significant economic burden stemming from healthcare costs, including frequent emergency department visits and the ongoing expense of epinephrine auto-injectors, as well as productivity loss from missed school or work days. To mitigate these long-term challenges, comprehensive management strategies are crucial. This involves regular follow-up with allergists, access to psychological support for anxiety and fear, participation in patient support groups, and continuous patient and family education to empower self-management and advocacy. To ensure consistent and high quality care, leading international allergy and immunology organizations regularly publish clinical guidelines and consensus statements. These include prominent bodies such as World Allergy Organization, the European Academy of Allergy and Clinical Immunology, the American Academy of Allergy, Asthma and Immunology, and the Global Allergy and Asthma European Network. Their key recommendations are remarkably consistent. Epinephrine is the unequivocal first line treatment. Personalized emergency action plans are essential. Strict allergen avoidance is crucial. Comprehensive patient education empowers individuals, and specific immunotherapies are recommended for certain triggers. A major recent shift driven by evidence is the advocacy for early allergen introduction in infants at high risk to prevent food allergies. These guidelines also clarify the role of adjunctive therapies, stating that with antihistamines and corticosteroids may be used, they are secondary and do not treat the acute life threatening symptoms. Crucially, post anaphylaxis care emphasizes the necessity of referral to an allergist or immunologist for thorough evaluation, trigger identification, and long term management planning. The overall aim of these comprehensive guidelines is to standardize the diagnosis, management, and prevention of anaphylaxis, ultimately working towards the improving patient safety and outcomes globally. Thank you very much for your time and attention, guys. Anaphylaxis is a complex but manageable condition, and I hope this comprehensive review has been insightful. Please feel free to reach out to me in comments or DM me in Instagram if you have any further inquiries or would like to discuss this topic further. And please like, share, and subscribe to the Docsaab's Diary. Thank you.